As you see on the screen in front of us, the conversation is going to focus on how we can harness data and evidence to accelerate action. My name is Grant Baldwin. I direct one of the divisions at the Centers for Disease Control and Prevention, the one that's largely focused on dealing with the CDC response to the opioid overdose epidemic. When you think of the CDC guidelines, our large state-based programs, that all comes out of my division. So we have a fantastic panel, as I alluded to. Each of us is going to be speaking for about 8 to 10 minutes, and that will give us around 20 minutes at the end, hopefully, for Q&A. So I want to go ahead and, if you haven't already looked at in your app, I'll just very briefly introduce Aliese and Haley. You met Chris this morning. So Aliese Alter is going to follow me. She is the ODMAP program manager from the Washington and Baltimore high-intensity drug trafficking area. In this role as the program manager, she's responsible for the overall management of the program, including outreach, program development, implementation, and national partnerships, which as you'll hear, because the program is expanding so quickly and so robustly, is critically important. Prior to joining the Washington-Baltimore HIDA, she served as a detective for the Henrico County Police Department. And then also speaking after Chris is Haley Akah. She is a health policy analyst at the Health Policy Institute of Ohio. She leads the Institute's Addiction Evidence Project and analyzes key health policy issues such as population health, prevention, healthcare access and quality, and social determinants of health. She holds a law degree and a master's in public policy from the Ohio State University. And I can say that because I have two degrees from the University of Michigan. It's troubling, I know. I don't think she realized that before she got on the stage with me. It's like, wait a minute, hang on. I don't know if I got into that. So our aim for this session, it's fairly straightforward. We want to help you do more, achieve more, and innovate more to help turn the tide on this epidemic, and hopefully put some more ideas or have some of the ideas that are on the four walls around us pop out to you. I'm going to focus the bulk of my remarks on CDC's large-scale overdose data to action cooperative agreement, so aptly named given the focus of this hour together. I'll talk about each of the component parts of the program, surveillance and prevention, how it's evolved, what's changed, and frankly, how we're trying to incentivize the outcomes that we're hoping to see. I'll also talk about, and we've heard throughout the day, of the importance of the growing partnerships between public health and public safety. We're investing in a program called localities, which I'll explain the acronym later. I'll talk about that. And then I'll close by talking about some of what we're trying to do with the CDC opioid prescribing guidelines, some of the other resources that we have available, including a key communication campaign. So our North Star at CDC and the Injury Center as it relates to the opioid overdose epidemic is to reduce overdoses and overdose deaths now. There is an urgency in the now for us, while at the same time we need to be thinking long-term, sort of big P prevention about how we reduce risk that would put somebody at risk for subsequent substance misuse, abuse, and potentially death. The work that we do at CDC complements the work that others do in this space, SAMHSA, HRSA, and FDA. And the 5 pillars that you see listed on the slide are really undergird that North Star. They are to improve data quality and track trends, to strengthen state, and now importantly, and I'll talk about this with OD2A, and especially given Josh's talk as well at lunchtime, local and tribal implementation of evidence-based programs. You're all familiar with the CDC opioid prescribing guideline. That third pillar is to improve patient safety by giving clinicians the data tools and resources that they need. Strengthening the partnership between public health and public safety to identify threats, to help link people into treatment, and to implement some novel interventions is our fourth pillar. And finally, to empower consumers to make safe choices. This is a large-scale communication campaign with the tagline, "It only takes a little to lose a lot. Prescription opioids can be addictive and dangerous." That campaign's very successful. I'll talk a little bit about that and how we're trying to evolve that program. So Overdose Data to Action is really the coming together of 4 previously funded CDC cooperative agreements. 2 in the prevention space, Prevention for States and Data-Driven Prevention Initiative, 1 in the surveillance space called ESOS, that attends to both fatal and non-fatal surveillance, and then some bridge funding that we used last year with a program called S2, or Surge Support. All told, right now, CDC is funding all 50 states and 4 territories to do this work. OD2A is a marriage of those 4 programs, and it's going to be, when we first started writing it, we called it the mega NOFO, but it constitutes nearly $1 billion of funding. It's a 3-year cooperative agreement. As I said, we're marrying the surveillance and prevention components for a whole variety of reasons, because it, frankly, integrates what we want to see happen and what the conversation right now is about, integrating data and action. It's going to streamline reporting, budgeting, staffing, et cetera. And we're using a 3-year time horizon instead of the 5-year time horizon. To a certain degree, we're regretting that a little bit right now because it's so much work to get these funds out the door. But we did that in part because this epidemic, this polysubstance epidemic that we've heard throughout the day, changes so quickly. We wanted to maintain some nimbleness as well. This is also the first time that CDC is going to be funding big cities, 19 cities potentially, as well as 20% of the prevention dollars need to go directly to the hardest hit communities. So that's an exciting change for us. On the surveillance side, on the morbidity side, we are going to require states to report on a wider variety of indicators, so not just drug and opioid involved, but now heroin and, importantly, stimulant-related non-fatal ED visits using our syndromic platform, trying to increase the coverage that we get from 50% of ED visits to 75%. And we are giving more money to states that give us data faster. So you get an additional $250,000 if you report data to us within 2 weeks. You'll hear, frankly, from Aliese in a few minutes about, really, for us to be able to use data that we get, we need to have it in more real time. Just not that long ago, the vital stats data that we are getting was 2 years old. And that really, we need more timely data to do the work that we're trying to do. On the mortality side, not just, now we're including all drug overdoses, not just those that are opioid involved, so that's important. We're also going to be given an additional $200,000 to states that report within 2 weeks of suspected drug overdose. All in the intent, again, for us it's comprehensive, localized, and actionable data. That's what we're really going for. On the prevention side, the large bit of funding that we had historically was to enhance and maximize the use of prescription drug monitoring programs. We're going to continue that. We're going to focus largely on intra and interstate interoperability. That is, if you look at your state's PDMP, are you making sure it's pulling in data from neighboring states or states where people may be going to get prescribed medications? But then importantly, as I've talked to several folks throughout the day, how do you make sure that data is integrated directly into clinical workflow? And so we're investing in that. We're also on the CDC prescribing guidelines. We're trying to make sure that those are best implemented through tracking and quality improvement measures, as well as efforts to enhance academic detailing. I already talked a little bit about how we're trying to integrate more in states and localities, and I just got my 3-minute warning. So let me go with the next slide. So this is our KUCLI program. This stands for Combating Opioid Overdoses Through Community-Level Interventions. I talked to the person who helps run this program, Rita Noonan, and she said to me, think of this as innovation accelerators. So these are, we invested in 13 KUCLIs, 8 new ones in this fiscal year, innovative, evidence-based, community-level interventions. This adds on to some of the funding that ONDCP is providing for the program. You can see on the slide here some of the kinds of community-level programs that we're investing in. ED-initiated referrals to MAT in Philadelphia, post-arrest diversion to treatment for opioid use disorder in Kingsman, Arizona. And let me highlight just one more, the one at the bottom here. This is, part of that big P prevention that I started talking about is how can we, there's a really fantastic program in Martinsburg, West Virginia that's both trauma-informed care from adverse childhood experiences, but then just thinking about how you can disrupt the cycle of substance use disorder that many families struggle with. So this is my final substantive slide, and it includes some additional resources that we have. On the far left is a new, recently released coordinated care plan. This is for hospitals and health systems that are wanting to implement opioid stewardship programs. How do you do that? What needs to be in place? How do you find a champion to do that? So we've developed this protocol, piloted it in a number of health systems, and it's now on the street. I think it's absolutely fantastic. It also includes a bunch of QI measures that health systems can use. In the last session that I participated in, there was a good conversation about the opioid prescribing guidelines that CDC put out, came out in March of 2016. Just this April, there was a commentary that the guideline authors put out in the New England Journal of Medicine. If you haven't seen that, I would encourage you to see it. It basically tried to clarify some of the guidance that exists in the original guideline, but wasn't sort of top line, top of the marquee information around abrupt discontinuation of patients, how you taper, when to taper, et cetera, and frankly, what those guideline thresholds mean. Not hard stops at 50 or 90, but rather what it's intended to be, which is just a guideline. In the center, as we've increased the partnership between public health and public safety, we were frequently asked, what does the evidence look like? So Rita Noonan, Jessica Wolf, and Jen Carroll put together this document. This is a cadre of what works, from targeted naloxone distribution, 911, Good Samaritan laws, obviously syringe service programs, MAT, which we've talked about within the context of criminal justice populations, et cetera. Academic detailing is also highlighted. On the far right is that communication campaign that I talked about. I would encourage you to Google it later. If you've seen CDC's Tips from Former Smokers campaign, it sort of takes a page from that playbook. So this is people who've lost loved ones to this disease, as well as people who are in long-term recovery, their stories, and trying to link people ultimately into care and treatment. And we're evolving that campaign both from a diversity perspective as well as its scope beyond prescription opioids. So I think that's what I wanted to say. Next and final slide, I'm trying to be more intentional about saying thank you. Thank you for all that you are doing to help turn the tide on this epidemic. Thanks for the innovation. This has been an incredibly rich conversation with a lot of intellectual capital. So I look forward to the panel conversations that I will moderate after this. So, Aliese?
Thanks, Grant. Typically, I don't write any type of notes to kind of stay by, but given the time and also so much to cover, I have guided myself with a script here to stick to. So when I was a police officer and a detective, I responded to overdoses every day during the introduction of fentanyl, which led to chaos. First responders nationwide encountered fentanyl and synthetic opioids on a scale never seen before. At that time, many were unarmed with naloxone and received no guidance, so business continued as usual. First responders continued with what they knew to show up and to save lives. However, many realized that that very routine was paralyzing and lethal as overdose deaths continued to rise at alarming rates. I wanted to take the opportunity to give a personal story that puts this concept into perspective. 1 year ago today, I was a detective in Richmond, Virginia. During my 6 years, responding to overdoses unfortunately became the normal. I recall being assigned to evening shift patrol in 2013 to 2016 and responding to my first overdoses. We weren't equipped with naloxone, and quite frankly, we didn't even know what it was. Oftentimes, I'd be the first on scene of an overdose, and I would just be waiting for EMS to arrive to administer naloxone. It wasn't until my curiosity got me that I asked the paramedic what that was that they were giving them. And it was many years that went on until formal education came out to us on what opioid overdoses were. And that's how business continued to occur, and unfortunately is still occurring nationally in many places. The lack of sharing and communicating across disciplines is real. I recall this being seen every day, and I recall many people that I became encountered with during my times on patrol. One specifically was Rebecca. Unfortunately, at that time, our agency protocol said that if I came in contact with anybody who had any type of drug or paraphernalia on them, that I shall arrest them. So unfortunately, I had arrested Rebecca many times. I got to know Rebecca, and we developed a pretty good relationship where we encountered each other outside of my patrol car. And eventually, Rebecca was accepted into drug court, where I was actually invited to her graduation, but I was unable to make it. Not too long later, I got dispatched to a death at Rebecca's home where her mom had passed away, and so I was working the drug investigation. And so I knew in my mind that with Rebecca being recently released, with the trauma of her mother dying, who was her only living relative, combined with other trauma that she had endured throughout her life, that she was at risk more than ever. But I had no resources to direct Rebecca to, just my conversation with her, where we did develop a relationship where she would call dispatch if she wanted to talk, and we did. I remember being on patrol not too long later in the mall, which was in Rebecca's beat where she lived, and her boyfriend came up to me and he started talking to me and he asked if I had heard about Rebecca. And I was like, no, and he told me, unfortunately, Rebecca had overdosed and passed away. And unfortunately, this became so common for me and for many first responders nationally. And so oftentimes we wait, when it comes to data, we wait until we can identify, the Overdose Detection Mapping Application Program, or ODMAP, was a concept that's engineered to break this very routine. ODMAP features two platforms, Level 1 and Level 2. The Level 1 platform enables users to enter a suspected overdose in near real time in effort to stimulate and mobilize a real-time response. Level 2 displays suspected overdoses at the national level on an interactive map. Oftentimes, disciplines become accustomed to operating in a familiar world with comfortable data sets. ODMAP offers the ability to break the customary boundaries and to share data across disciplines, serving as a centralized repository for suspected overdoses in naloxone administrations. Data collected in regards to overdoses is often collected based by agency, county, state, or region. However, drugs don't abide by geographic boundaries. They will continue to cross agency, county, and state lines. It's paramount that data sharing occurs not only at the agency, county, and state level, but at the national level. Oftentimes, when it comes to data, we wait until we can identify and define an exact and specific time frame relevant to the data we are examining in an effort to produce a statistical result with some level of confidence. We are not afforded that luxury during a public health emergency. ODMAP data is near instantaneous. It is suspected overdose data as they are occurring. We do not have toxicology or crime lab results. We just know someone has appeared to have overdosed, fatally or non-fatally. ODMAP can harness this data and evidence and accelerate action. Since the creation of ODMAP, several models for utilizing data have emerged. Some of these best practice models focus on outreach, and others use data after overdoses have occurred, and some focus on real-time response. I'd like to take the opportunity to highlight Erie County, New York. The Cheektowaga Police Department and the Erie County Health Department were early adopters of ODMAP and developed an innovative strategy which has shown early results. When CPD officers respond to an overdose, they leave a package of introductory educational materials about substance use disorder. A health department staff member monitors ODMAP Level 2 for suspected overdose submissions. When a new overdose is identified, the staff member contacts CBD Records Department to receive a copy of the police report. Since ODMAP does not contain any personal identifying information or PII, this is an innovative method to identify the victim. Once the victim is identified, the health department's peer recovery specialist attempts contact with the victim in order to connect them to resources if interested. They also have several other prongs to this plan, which we don't have time to discuss, but I'm always happy to discuss them. The slide right here shows some basic overviews. Across the country, we have seen several best practices related to the use of overdose response teams during ODMAP-identified spikes. Recent examples have occurred in Oklahoma, Minnesota, and New York. I'd like to highlight St. Paul Police Department in Minnesota, who put out a press release on the recent efforts surrounding ODMAP. St. Paul Police brought in their mental health unit, renaming it the Community Outreach and Stabilization Unit, or COAST. The new name is intended to highlight the expansion of the program. COAST has officers, research analysts, and social workers embedded within the unit, and earlier this month, the St. Paul and Washington County areas saw 4 deaths and more than a dozen overdoses believed to be linked to a bad batch of heroin, likely laced with fentanyl. Departments within this area received spike alerts from ODMAP, allowing them to be aware of what was occurring in neighboring counties. The alert allowed for police to administer a public safety overdose warning, which included information about the state's Good Samaritan law and naloxone usage. The COAST team also deployed to known hotspots identified in ODMAP to warn of the bad batch, as well as provide information and resources. The overdose epidemics and oftentimes the general nature of first response is reactive rather than proactive. Spike alerts offer the opportunity to see what is on the horizon and what it could be coming and respond. The next slide represents spike alerts which occurred during the first weekend of June along the East Coast and Interstate 95. While these alerts are not statistically verified, localities often know where their most common source cities exist. So in this example, if Baltimore, Maryland is a source city for Richmond, Virginia, Richmond could create spike alerts for Baltimore, and in this case, it could have served as an early warning of when a spike may be on the horizon. This anecdotal evidence does not replace scientific or academic research, which will likely be forthcoming in the future. However, we need data that allows us to act immediately and save lives. We can't arrest our way out of this problem, we can't ignore it, and we can't wait for our data to be perfect. In order to combat this epidemic, we not only need data, but we need to ensure that all members of our team, regardless of discipline, are looking at the same data. By utilizing multidisciplinary teams, we can put this data into action and to save lives. I would also be remiss if I did not take this opportunity to recognize ONDCP, which the HIDA program is administered through, for their constant support, as well as BJA and CDC. BJA recently announced the ODMAP statewide expansion and response grant solicitation in coordination with CDC, which focuses on supporting data collected through ODMAP to deploy public safety and public health interventions. This grant opportunity mirrors so perfectly the wide range of strategies which can be utilized to harness data and evidence to accelerate actions with diverse and innovative partnerships. Thank you for your time.
Yeah.
So I'm going to talk about the need for us to do intensive evaluation with the law enforcement assisted diversion pilot that we did in Seattle, and sort of the policy world implications of that. Before I do, I just want to tell you a quick story. We were sitting here before this panel started, and I was saying that these really bright lights made me feel like I was in an interrogation room. And then I suddenly remembered something that we had done early on before we actually started doing the LEAD program in Seattle that is actually part of an evaluation process for some people. So, and I don't want to claim that we were geniuses about this. This was like a total stroke of blind luck. This was a blind squirrel finding an acorn. But we had gotten a small amount of money to do a focus group prior to doing LEAD. And so we got about 23 officers who were going to be the first group of officers to be trained in doing LEAD, and who were going to roll this out on a pilot basis. And we brought them into this room with two-way mirrors. And, right, these are all police officers. They know what that mirror is, and they know exactly what is happening on the other side of that mirror. And so they were like totally stoic. They just absolutely weren't saying a word at all. And luckily, the woman who was running the focus group was really good at her job, and she could tell that she was not having any success. And so she shifted gears, and she threw away her script. And she finally asked them, she said, so you guys are police officers, and she said, do you ever get told to do things just randomly that make no sense to you, and that you don't understand why you're doing it? The dam burst. So immediately, every single one in the room had 2 or 3 examples of edicts from on high that had come down in the past that they were told to change policy overnight, and they could never figure out why they were doing it or what the utility of it was. Anyway, once the dam burst, then they started giving real concrete feedback about what their impression of LEAD was, and it was not very good. And there was a lot of deep resistance and skepticism to being involved with it. And so when we actually met with them, not inside the focus group setting, a couple of weeks later, and we came in and we showed them in a track change document where we had changed the protocols for LEAD in response to that focus group, their thinking shifted right away. You could just see their body language change. You listened to us? You actually paid attention? You changed something because we asked you to change it? Oh yeah, we'll work with your program. So that's just one example of like sort of pre-program implementation of doing some like feedback with some of your stakeholders. and being responsive to that feedback. If they're telling you stuff that you either didn't know or that you didn't want to hear, in order to make that program successful, you may have to adapt it to what they're telling you. So we did that. So now what I'll do is just quickly tell you that our evaluation plan and things, we had to change things. So when we started LEAD in Seattle, we were entirely private foundation funding. We had asked a couple of large foundations to give us 4 years of money. And we told them that we would operate as normal for 2 years. We would evaluate in year 3, and hopefully the evaluation results would be good enough that we would be able to transition to public funding. So everyone agreed to that. But what happened was we got thrown a major monkey wrench in that about a year and a half into doing LEAD, the qualitative anecdotal level of success for the program was such that people who lived in neighborhoods adjacent to where we did it went to the mayor and city council and said, how come Belltown has LEAD and we don't? And they put so much pressure on the city council that they actually appropriated funding, public funding, to do LEAD. But their caveat was, we will not renew this funding without an evaluation. So suddenly, we had to fast track our evaluation. And I'm not going to bore you with details. We were really fortunate. Another large foundation stepped in to pay for a $500,000 evaluation from an independent team of researchers from the University of Washington. So what we then did was we started an evaluation advisory committee, because now we knew what we needed was an applied evaluation. We needed an evaluation that was going to resonate with policymakers. So what we did was we got central staff from both the city and county council. And for those of you that work with governmental agencies, you know it's the legislative aides that do everything. And the politicians just come and sit in the dais every once in a while and pontificate. Meanwhile, it's the people in the back rooms that are doing it. And so what we told them was, these central staffers, we were like, we need you to tell us what you need to see in the methodology. We're not asking you to tell us anything about the results, but what do you need for the methodology to be sound, for you to be able to tell your bosses when it comes time to appropriate money, yes, this was a high-quality evaluation. So we spent a tremendous amount of time in the background before we even started the evaluation, making sure that all of the relevant partners were agreed with the methodology. So that's just sort of the quick story there. I can answer more questions about it later. What I will say is that for the politicians, the 2 things they were most interested in was, not surprisingly, recidivism and cost. And so we did a really high-quality, rigorous recidivism evaluation, which fortunately for us showed that people that were diverted into LEAD were 58% less likely to be arrested on brand new offenses than individuals who were routed through the criminal justice system. Quite honestly, this came as a shock to most of us. We were actually prepared for a wash on the recidivism, or maybe even that it would be a little worse. Our money was all on the cost evaluation. And so the fact that the recidivism outcome was as good as it was really prepped us. And then we did do the cost evaluation, and unfortunately, the only thing we were able to look at was criminal justice system savings. So we compared criminal justice system costs for the LEAD group versus criminal justice system costs for the control group, and a variety of other metrics. What we were not able to look at was savings like in the healthcare system, reduced emergency room access, reduced other care. We're going back now, and we think we've figured out a way to do that, which will be even more compelling in the end, we hope. So with that, I will leave it there, and we can hopefully address any questions you have later.
Hi, good afternoon, everyone. My name is Haley Aka. I'm with the Health Policy Institute of Ohio. And as much as I love my home state, I am thrilled to have spent the past few days here in California. So wonderful to be here. I'm also thrilled to be on a panel all about data and evidence. As a policy analyst, this is my bread and butter every day. I think that this topic is fascinating and important. I hope you think so too. But even more than that, the policy change angle, the usefulness of the data and evaluation is really where we want to get to, how we can get this stuff in the hands of our policymakers to make change as it comes to the opiate crisis. So I'm going to be sharing a little bit about how we are translating research and evidence and publicly available data into calls to action for our state policymakers in Ohio. So HPIO is a nonprofit, nonpartisan research institute. Our mission is to provide the independent and nonpartisan analysis needed to create evidence-informed state health policy. And that's the mission that frames all of the work that we do, and particularly our work on the Addiction Evidence Project, which I'll share about here in a sec. So we started this work in 2017 when a group of our stakeholders identified to us a need for an independent organization like ours to catalog all of the research that exists on how to address addiction and then translate it for our policymaker audience. The sense was that we know what works. We know what works to prevent addiction. We know what works to treat substance use disorder, to distribute naloxone, to defer people from jail and into treatment. But that more could be done to harness that knowledge and put it in front of our policymakers to impact our state level policies. So that became the goal of the Addiction Evidence Project, to provide policymakers and other stakeholders with the information that they need to evaluate our policy response to the opiate crisis thus far, and then to continually improve the strategies that we're using to address substance use disorder in a comprehensive, effective, and efficient way. So here on the slide, you'll see our framework for the Addiction Evidence Project. It highlights the comprehensive approach that's necessary to end the addiction crisis. And this comprehensive approach has a couple of implications, right? First, it means that we need to partner with many sectors to do this work. It also means that we need to understand each of these areas with depth, and that we need to understand how the areas connect. So in this work, we have to go both deep and wide in our approach, which means that we're going to learn a lot and we're going to collect a lot of information. That's why meetings like today are so important. But all of that information can be really difficult to put into a two-pager that a policymaker is going to read, right? That's a real challenge. And so that's why we decided to take a phased approach to this work, so that we could kind of summarize and tailor that information so that our policymakers could use it. So we first took on the prevention, treatment, and recovery section of the work that was completed in the middle of last year. We then worked on harm reduction and overdose reversal, finished up last year. We're now in the midst of our law enforcement and criminal justice work, so I've been fascinated to learn from my colleagues on the panel and others of you today who know much more about that than I do. And we'll continue around this framework until the project is complete so that our policymakers get all of this great information. Next slide, please. Within each phase of the work, there are three aspects. There's the evidence resource page, the policy inventory, and the policy scorecard. And I'm going to talk about what each of these phases contain really briefly, and then walk through an example so that you can see how elevating the research evidence in this way can be really helpful for inspiring policy change. So the first thing that we do is the evidence resource page. This is where we ground ourselves in the evidence on what works to address addiction. We look to the most credible sources of information that are available, and this includes expert consensus statements, clinical guidelines, and evidence registries whenever possible. And we've heard some great examples of these today. That includes the Surgeon General's report, Facing Addiction. It includes the CDC clinical guidelines. It includes What Works for Health out of Wisconsin. And once we collect all of this great information about what works, we put that up on our website, and that's our evidence resource page. We then move to our policy inventory. This is where we pull together all of the policy making that's happened in our state around one of the topics in the framework. So we search our Ohio Revised Code, our administrative code, all of the policy summaries that we do in our executive agency so that we can capture all of the state programming and initiatives from the executive branch. All of this is to answer the question, what is Ohio doing really to address addiction? We then put these together in a scorecard. This is where we bring together the research with what Ohio has done to identify our next steps as a state. We analyze the evidence-based policy, compare it to the policymaking that's happened in Ohio, and then identify strengths, gaps, and opportunities for improvement that we can elevate to our policymakers. So really quickly, I'll go through an example related to naloxone distribution. So in our evidence resource page, we found, unsurprisingly, that research supports wide availability of naloxone. And one policy to get at that is to allow organizations that cannot typically dispense prescription medications to be able to obtain, store, and dispense naloxone. So in our inventory, we looked at, okay, what is Ohio doing around naloxone availability? And we saw that we're doing a lot, but that in Ohio, we have a licensing requirement that any entity that wants to distribute dangerous drugs, which includes naloxone, in our state, they have to be licensed as a terminal distributor of dangerous drugs, or a D license. Law enforcement is exempt from this, but other organizations like local health departments or other community orgs are not exempt and have to get TDD licensed in order to disperse naloxone. So in our scorecard, we saw we're not really doing this evidence-based practice. You can get naloxone, but it's hard. There's this administrative burden. And so we elevated this opportunity for improvement to our policymakers. And this last month, at the beginning of June, our pharmacy board adjusted their policy. And now organizations that are TDD licensed can store their naloxone in other facilities and other organizations who can also distribute. So by elevating this evidence-based practice to our policymakers, highlighting as an issue, policy change really can happen. And this is just one example. We've seen several others that hopefully we can talk about on the panel. My last slide I'll cover very briefly. It's so encouraging to hear from my fellow panelists about the great programs that they're involved with and the excellent data that they're able to capture and elevate and distribute. Unfortunately, this is not the norm for state policymaking in Ohio. And of the 244 policies that we reviewed in the first two phases of our addiction evidence project, only 33 included a clear reference to an evaluation component or any sort of tracking of outcomes at all. And so because of this, the impact of most of the policy changes that we're making are not assessed or documented in any sort of rigorous way, which is unfortunate, particularly in the midst of a crisis and with the flurry of policymaking that's happening, particularly in our state at the epicenter of this addiction crisis, right? And you can see this quote on the right-hand side from one of our Ohio House of Representatives who's expressing frustration at the fact that our state continues to spend money on programs without really knowing if they're working for Ohioans. So we can continue to put the research evidence in front of our policymakers and educate them about the policy changes that are likely to have the most impact for addressing addiction, and we should. We absolutely should be doing that. But we also need to advocate for data collection and program evaluation so that we know whether the policies that we're implementing are really achieving the outcomes that we intend. So with that, we'll move to our panel conversation.
Great, thank you so much. Well, we did what we said we promised to do. We have now 20 minutes of time to have a conversation. This is where you press us on what you heard, or frankly, share other ideas, other catalytic ideas to move this conversation forward. The brain trust of how we're gonna continue to move forward and innovate is right here in this room, so we wanna hear from you.
Hi, thanks so much. Jen Hastings from Santa Cruz. I'm part of the Health Improvement Partnership of Santa Cruz County, and I provide buprenorphine through our mindfulness-based MAT program. We're having a real problem in Santa Cruz with our public opinion. So we have a large homeless population. We have increasing syringe litter, as they call it. And turns out that when our county went to our Board of Supervisors to request an increase in hours, to get kind of formal permission to do secondary needle exchange, to basically follow evidence-based harm reduction policies. The public opinion was such that our Board of Supervisors basically turned down every request. And so we're stuck. And I really want to know from our panel and from the audience, how do we really decrease stigma and allow communities to follow harm reduction, evidence-based harm reduction approaches?
Thank you for your question. Who wants to take that on? Yes, Aliese.
Is this on? Okay.
Yep.
So I actually had a recent conversation after a presentation I did in rural in Southern Virginia, and there was they have a very progressive coalition for the area, and the members were very interested in putting in some type of harm reduction services into the community, particularly because their homelessness population was astronomically high given their population, and they also had the issue with discarded syringes in the area. And Roanoke is kind of a tourist center for Virginia too, so they're very concerned with what the public sees of them when they're visiting, right? And so I went down and I did a presentation to their collective response, and I'm driving home and I actually get a call from the police chief, and he's telling me, you know, he's very disgruntled that they want to put in this syringe service exchange area and that they want to do it at the police department. And so I was like, well, let me take the opportunity to kind of hear your concerns on that and hear where you're coming from. And so he explained it, and it was, you know, it was, given his background, he hadn't really delved into a different mindset, right? So it's kind of the opportunity for him to see it through a different lens, and I think that's what really needs to be done with this epidemic, is traditionally we're really good at seeing it through our own lens, right? We know what we're supposed to do in our department, we know our protocols, but a lot of times we have absolutely no idea about our partners. And so for him, it was just offering the capability to help facilitate those conversations, because they just hadn't been had yet, and it was kind of a missed opportunity that had occurred over and over and over again, and frustration, right? Because neither one was hearing the other person. They weren't listening, they weren't hearing them, they were just responding with what they knew. And so I always say, you know, resistance isn't a bad thing. You know, if you're at least having engagement and you're being turned down, you have to be persistent. And so I think just taking these opportunities to maybe open up the dialogue and having more of just an open and collaborative session can really open the doors for change.
That's great. Chris, you want to add something?
I'll actually just jump in real quick with something, which is why those of us that work with evaluation and evidence-based practices, we also need to partner with people around messaging. And I'll just give you a really quick example of this that was told to me by a reporter for the Seattle Times. So he had been out interviewing a couple of homeless guys who had a broken down hibachi, and they were grilling some chicken that they had pulled from a dumpster behind a store, and they were using wood from a broken down pallet as the fuel. And so he interviewed them, and then he went about a block away and he came across a store owner who immediately erupted about, here I am at work and they're having a barbecue in the middle of the day. So, you know, it's like, how do you handle that perception? To this guy, these folks are just lollygagging and having a nice barbecue. Meanwhile, they're eating rotten chicken cooked on wood from a pallet.
I think it's interesting. I think there's some real implementation challenges that we need to wrestle with. I think we heard from the Surgeon General this morning about sort of balancing health and business interests. I've also been party to conversations where there's sensitivity. I mean, if you think they're having challenges in Santa Cruz, California, and you heard, I think, the heartening story from the Heartland from the SG this morning about the progress made there, I think we need to constantly evaluate, even though it's evidence-based, how do we do the implementation? How do we do the scaling? How do we evolve in ways to make sure that there's both the awareness and the implementation fidelity and progressiveness to make sure that SSP continues to have the necessary role within the community. Next question, please.
Hi, Kathleen West with AHP, one of the MAT expansion programs, and TP Reach from DHS. I wanted to ask Aliese a question as well. I love the ODMAP. It's just fabulous. And typically, HIDAs really do have amazing data that doesn't get out, I think, into the rest of the community, communities that are working with that same population. So it may be a very succinct question, or maybe need to elaborate a little bit. You said that there is going to be funding to expand those programs. Is this already happening, and is it already being implemented in other HIDAs around the country? And is this, speaking of messaging that Chris just mentioned, is this going to be able to be shared more broadly with a number of people that don't even really know what a HIDA is, and how to work with the HIDAs to really take advantage of this almost real-time data? It's a fabulous project.
Well, I appreciate those kind words. So, right, a lot of times people don't know what HIDA is, and so ODMAP being affiliated with HIDA sometimes can be confusing. And so there are grant opportunities out there from our federal partners, specifically BJA and CDC. So Grant talked about the overdose data to action, so that's ODMAP is built into that as one of those options, as well as several of the BJA COPE grants that are out there. So you can absolutely apply for those. So there's some more county site level grant opportunities out there that encompass ODMAP, as well as the large statewide ones that are out, or the one that is out currently that actually ends in 2 days if anybody's on the deadline currently. And so for the data, ODMAP's available to government entities serving the interest of public health and public safety, as well as EDs at hospitals and any licensed first responder. So the idea is really anybody who is kind of participating in this epidemic, that they have access to that data. And there's also a plan for nonprofits and coalitions. Obviously, you and they play a huge part and role in this. And so they just partner with their local or state department has access. So typically they're partnering with their health department to gain access. And so absolutely to share that data. And of course there is some sensitivities around the data as well, right? So anybody who enters in the data, it's their data. Us at the ODMAP program office, we're just the data stewards and make sure that data stays protected. So there are some systems in place to protect data as well, since it is being viewed at the national level.
ODMAP is incredibly simple to use. I mean, literally, if you have a smartphone, and virtually everyone in this room does, if not everybody, it's just a couple of quick touches and you've entered that information. From CDC's perspective, we are very interested in marrying a drug intelligence or drug information officer with a public health analyst. So we are now in 11 HIDAs, 24 states, looking to expand nationally to bridge what do we capture within the context of public health? What do we capture within the context of public safety and law enforcement? How can we marry those data, link those data in a meaningful way long term? So we're, as part of the overdose response strategy, or ORS, we are looking to continue to expand that, and we have a lot of energy and eagerness to see ODMAP expanded more broadly. You've probably seen, I didn't have a chance to talk about it, there's ample opportunity within OD2A. In fact, $400,000 alone for each jurisdiction funded to innovate within the surveillance space. And ODMAP is one of those areas that we want to see invested in.
Yeah, I just wanted to tell my friends in Santa Cruz County, I've heard your frustration, but take heart. You are getting Dr. Gale from San Benito County, which is where I am. Maybe the supervisors didn't want to implement any new positions because they're getting a new doctor. I don't know that for sure, but I would suspect that, and she's an angel. You're going to love her. Your gain is my loss. Stacy McGrady.
We worry a lot at CDC about how you scale these programs. And so if you have creative ideas about how to do that, our CDC funding is intended to help undergird that, but the innovation that's happening starts here, starts at the local level, and then bubbles up to the federal level. So have a lot of energy on shrinking those timelines, a lot of energy on finding those innovative programs, those evidence-informed programs that we at CDC can invest in. Next question. Yes, please.
Hi, my name is Laura Chisholm, and I'm with the Public Health Division from the great state of Oregon. And thanks for this conversation. And you're probably aware that Oregon is a state that has some pretty strong libertarian values. One of the things, and this conversation about ODMAP is really helpful. We're looking forward to the opportunity to increase our implementation in the state with the Data to Action grant funds. We're waiting to hear about our notice of award. But I've also been hearing alarm bells from our colleagues in the harm reduction community about ODMAP and concerns that the data may be used to target people who use drugs and lead to arrest and incarceration of folks who happen to be bystanders of overdoses or are people who use drugs. So I'm curious to hear about what are strategies that we can put in place to help defend against that and make sure that that this is really a partnership between public health and law enforcement.
Yeah, so that's a great question too. And so that goes back to really understanding what the data is going to be used for, which I think is really important. And I had a call recently with some folks in Oregon, specifically a group of medical examiners that were coming on board, and they had some similar questions too. So the way that I overcome that is really getting into the nitty-gritty of ODMAP and showing them what the data looks like, and that there's no personal identifying information in there, number one. So it's pretty near impossible to identify who that person is. With that being said, for law enforcement specifically to utilize that information and that data and come back and use it in a prosecution or to build a case would be near impossible. And so really explaining, number one, when we're looking at having a county or an area come on board to ODMAP, hopefully we're having a multidisciplinary conversation too. So hopefully we're all coming to the table together, and so that we have an understanding of what the data looks like and what it's going to be used for. And hopefully law enforcement's coming to the table saying, we need help, and we need you to help us in this. And hopefully they've moved towards the mindset as well that they aren't interested in targeting people with substance use disorder, that they're interested in doing something like the LEAD program or doing a pre-arrest diversion program, and that ODMAP is really serving as the conduit and the platform to get us all on the same page in a real-time sense, 24 hours a day as the epidemic is happening. So I think it's a great conversation to be had, and I think it just goes back to looking at the data and all being on the same page of what we're going to use that data for.
And I think as we see more and more, and there's great examples, some of which I've heard about today, of some of the post-overdose outreach that's being done and the success of that and linking people into treatment, that's going to sort of reinforce how data is used in a meaningful way and to a public health good, not to a public health harm, and not have the chilling effect, which we are worried about as well, as you can appreciate. The other thing, in my travels across this country and talking to folks, I remember a conversation I had in Washington where we were talking about the expansion of the ODMAP program, and somebody from Buffalo was saying, the reality is some of these communities that are cash-strapped, and many of our communities are cash-strapped, when you're having calls to EMS 10, 12, 15 times for a single individual, we need to be smart about what kind of outreach we do to get those people onto a long-term path for recovery. And unfortunately, as a public health person, I have a certain lens of it, but if I was to put myself in the role of an elected official, they're trying to manage their community budgets, and that's just a reality. That sort of hit me stark in the face, because I had that very sort of, obviously we don't want this to have a chilling effect, and their counter to my argument was, yeah, but we also need to make sure we can manage the county budget. So something to be sensitive to for sure.
Hi, my name is Adamika Arthur, and I'm the executive director of a nonprofit called Health Tech for Medicaid. And I have a quick question, because I feel like one of the things we're missing as we talk about solutions is we're missing thinking about health technology as a way to kind of scale and innovate the opioid crisis.
Could you say a little bit more about what you mean by that? Health technology meaning what?
Sure. So oftentimes, we've talked a lot today about different populations. We've talked a little bit about different treatment modalities, specifically surrounding this epidemic, but we haven't talked about how do we scale, how do we innovate, how do we provide solutions to these populations, and usually that's done through the entrepreneurial community, through health technology lens.
How do you bridge addiction services or even sort of pain management consults into rural America? That's sort of been talked about, sort of leveraging telehealth in ways to get people access to the kind of definitive, advanced, specialized care that everyone deserves and needs, especially with issues as complex as this. But nothing's popping in the top of my mind. I don't know if there's others that want to weigh in on that health technology question. Other questions? Thank you.
Hi, I'm Janet Porter with the Pacific Southwest Prevention Technology Transfer Center. These are funded by SAMHSA. I have a question about, I know a lot of the money for the opioid epidemic, rightly so, has gone to treatment and secondary prevention. I'm wondering if you see more funding, Dr. Baldwin, coming down the pike for primary prevention, of which we have a very good body of prevention science. We know how to prevent substance misuse. SAMHSA has a strategic prevention framework that all the states are implementing. But this is woefully underfunded, and I'm wondering if you see more primary prevention dollars coming down the pike.
Absolutely. It's a question I've received on repeated occasions, and actually OD2A does give states the opportunity to invest in primary prevention. I talked a little bit about our work within the context of adverse childhood experiences, both funding things like, we just made a big investment in the Martinsburg Initiative. There are 3 priorities at the CDC Injury Center right now. One is opioids. A second is adverse childhood experiences. And obviously there are natural intersections between ACEs and subsequent substance misuse, abuse, and overdose. And so we are trying to invest more in sort of big P prevention. I think the challenge for us right now, and it's a balance obviously, when you have 70,000+ Americans dying of a drug overdose, we need to figure out, as Rita said to me the other day, if you're a surgeon and have someone bleeding in your OR, you need to figure out how to stop the bleeding now, while at the same time you stop patients coming into your OR. So the short answer is yes, CDC is going to be investing more in sort of big P prevention. We are in the process of developing strategically where we want to go with that. I would anticipate the sort of ACE community level interventions are likely to be a focal point of that. Don't hold me to that, but the earliest conversations that I've participated are anchored to some of that work. But those are, the challenge for us is those of us in service to elect people in elected office, they are in the short game. We want to play the short game and the long game. So for us, the challenge is how do we convince folks that we need to be playing the long game? And given the fact that everyone throughout the day has acknowledged this, we're really in a polysubstance problem, shifting from opioids to meth, cocaine. We didn't have much of a chance, although the SG talked a little bit about marijuana and its implications for us as a country. All of that is in play, and I think upstream big P prevention is what we need for that.
Hi, Wendy Still from Alameda County. I'm the Chief Probation Officer. My comment is related to the ODMAPs and the concern about sharing that information with law enforcement. As the community corrections person responsible for supervising over 8,000 adults and roughly about 750 juveniles, I have responsibility to create programs, right? And opioid programs are one of them. The ODMAP is really important, and I found myself as I was creating some of these programs looking for exactly that data. Where are the ODs taking place? And I wasn't interested in it for, who I could arrest. I can do that very easily. I was really interested in it for where the concentration of population and also the age demographics, right? Age, gender, etc., geographic location and such. So those ODMAPs can be just extremely valuable for prevention purposes for the law enforcement and those creating the programs.
When you see those spike alerts, and we heard some of the sort of the California trafficking networks, you look at I-95 in the Washington-Baltimore area, as she showed on that slide, guys, you can really see these, again, bad batches, trafficking networks. Those, if ODMAP is broadly implemented, you can watch them migrate up the corridor as those drugs penetrate the marketplace. Really powerful stuff. Well, hopefully we've met our aim, and this has been a good conversation for you. Thank you so much for your time. I think we have one closing panel to go. So thanks, appreciate it.